I am Julie Swaney. I am the Director of Spiritual Care Services at University of Colorado Hospital and also the co-chair of our University of Colorado Hospital Ethics Committee and on the organizing group for Ethics Grand Rounds. So welcome to Ethics Grand Rounds, and have a very, very good presentation today, and with two excellent speakers. Our topic today is ethical issues surrounding abortion in a post-Roe nation. And I want to introduce Dr. Jackie Glover, who is a certified as a health ethics consultant. She's a professor in the Department of Pediatrics and the Center for Bioethics and Humanities here at the Anschutz Medical Campus. She is the co-medical director of the Ethics Consult Service at University of Colorado Hospital and at the medical campus. And then also Dr. Heather Straub, who is assistant professor of Maternal Fetal Medicine at the University of Colorado Anschutz Medical Campus as well. So thank you both very much for this presentation, and look forward to this. And people can put questions or comments in the chat. So with that, Jackie and Heather, I will turn this over to you.
Thank you, Julie. Our learning objectives are these four, but we want to really concentrate not broadly on abortion, concentrate on the issues facing medical health professionals, and assuming full personhood, patienthood for both the pregnant woman and the fetus, and the need to balance that comes up in particular in the medical setting. So first of all, we really want to acknowledge, next slide, please, that this is very emotionally charged for everyone. It involves deeply held personal and professional values, and reasonable people of good faith really do disagree. So we're inviting you to pause and reflect with us, bringing your many perspectives, but reflect with us in particular about the ethical issues that are raised for our healthcare professionals in the setting of maternal fetal medicine, and in the setting of the Dobbs Amendment and many, many state restrictions. And as you know, language is very important in ethics, and language is so important in this dialogue. And we talk about the maternal fetal dyad on purpose. Dyad, bringing to mind that this is totally unique. One entity inside another entity, inseparable. And so what you call these entities really displays your orientation. And let's be careful with the language. One entity, patient, person, woman, mother. The other entity, patient, person, product of conception, fetus, baby. Let's attend to our language as we concentrate on the ethical issues that come up for the healthcare professionals in the medical sphere. So Roe v. Wade really tried to balance obligations to the pregnant person and the fetus. And so their balance was at viability, when the fetus could survive outside of the mother. And as Dr. Straub will talk about, viability is a squishy concept and a moving target. And so Roe v. Wade was really based on privacy and bodily integrity and respect for autonomy. It's an absolute in bioethics that there's no use of a person's body without their consent. It's an absolute in research. It's an absolute in organ donation. But the Roe v. Wade balancing didn't satisfy people for whom the balance is not necessary. For us, people who think that there's no balancing necessary because there's no limits to the choice of the pregnant person. Termination for any reason at any time of gestation And on the other hand, people were not satisfied because there's no choice, no balance necessary, because abortion is never justified. So no balance necessary. And as I said, we totally acknowledge, I totally acknowledge that reasonable people of good faith disagree. But there's no way out of the need to balance. You can try to talk about obligations always going to the pregnant person, or you can try to talk about obligations always going to the fetus. Roe said, reasonable people disagree. Based on bodily integrity and privacy and respect, the pregnant person herself can decide as a moral agent. She gets to decide what happens to her body in consultation with healthcare professionals, in consultation with her family, in consultation with religious advisors. In the face of irretractable disagreement, she gets to decide. Dobbs said, no, there's no individual right to privacy in this at the federal level. In the face of disagreement, the states get to decide. And so state by state, states have been coming up with various laws. Some states reinforcing Roe, some states getting rid of abortion completely. And you must really realize the law is a very blunt, I'll say it 3 times, blunt instrument. Trying to attend to and fix one problem has resulted in a cascade of other issues. So we're concentrating on before and after Dobbs. Some institutions, including our medical center, which with its maternal fetal medicine program, has 2 patients. Some institutions only have 1 patient, like Planned Parenthood. We are assuming for this dialogue that we do have 2 patients and 2 full persons, moral status for both entities. But you can't ignore the need to balance. Dr. Straub is going to talk about balancing for the life and health of the mother and balancing for life of other fetuses. In our literature, Frank Trevanick, is he MFM or just OBGYN?
I believe he's MFM.
Yeah, our colleague Frank Trevanick, who's an MFM doc, and Larry McCullough, who's a philosopher, really came up with guidelines for obstetric ethics. And they, on the one hand, fetal rights is really reductionistic. And on the other hand, pregnant women's rights is really reductionistic. We engage in rights language all the time, as though it answers the moral questions. It just begins the conversation. What is a right, after all? A right is a really, 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 really important obligation, a claim on the behavior of others. I'm not talking about a legal right. This is an ethics discussion, but an ethics right really is an obligation. If you claim a right, someone has a correlative obligation to either refrain from doing something or to give you something. So let's just stop the polarizing rights language, which I think Trevanick and McCullough would agree with. And let's talk about responsibility language. And so they outline the professional responsibility obligation. To the pregnant woman, it's an autonomy-based obligation and a beneficence-based obligation. To the pre-viable fetus, it's a beneficence-based obligation if the fetus is presented as a patient by the pregnant woman and at viability. So that's a very practical and well-supported framework that maternal fetal medicine, very influential in maternal fetal medicine. And so that's the ethical framework that we're going to be based on. Our obligations of respect for autonomy and also respect for beneficence, well-being of the other entity, the fetus, the baby, and how do you balance them, and not harming? How do you balance them? So take it away, Dr. Straub.
Thank you. So I just wanted to mention before I get into my section of the talk, there are a few medical pictures and cartoons of fetuses with a variety of complications. They may be distressing to people, so I wanted to just let people know we're also talking about very complicated situations where there really isn't a right or wrong answer. And this is what a maternal fetal medicine does on their day-to-day job, is trying to balance the health and welfare of their two patients. And so wanted to jump off with this case. A patient is a 23-year-old with their first pregnancy, presenting at about 4 months for a new condition, which is both instigated and worsened by the pregnancy. When imaging was performed to address the new condition, it showed that the fetus has a malformation, which will likely cause a stillbirth or death shortly after delivery. She and her family are devastated by this news because this is a desired pregnancy. And they are given the options of delivery now with the strong probability of a vaginal delivery, or delivery later, which may mean a cesarean delivery because of concerns related to obstruction due to this malformation, which will grow and progress over time. This family elects to have a vaginal delivery and comfort care of the baby. The baby is delivered vaginally. It is baptized and dies about 2 hours after birth. Jackie mentioned that language is so important, and in this case, language is very important. Is this an abortion? Is this a preterm birth? Would the answer change if the baby happened to be stillborn? Would it matter if the baby didn't have a lethal or life-limiting anomaly? Would it matter if the medical condition of the mother or pregnant person would only slightly worsen during pregnancy? And would it matter the gestational age where this was found, 2 months versus 4 months versus 8 months? In the pre-Dobbs world, these were the types of decisions that were taken upon by the doctor and the patient and their family, gathering medical decision information, and then doing a values assessment for the family to try and determine the best path forward. However, in a post-Dobbs world, the question is who gets to make this distinction? Is it no longer in the hands of just the family? There are restrictions in various states that would classify this as an abortion. Other places would consider this a preterm birth. And so it becomes very complex in an already complicated situation to allow patients to make the right decisions for themselves in a very, very difficult situation. We're going to talk a little bit about some more definitions. And as you see, there can be medical definitions, and then there can be community-based definitions, and they don't universally apply. So if you look in the Oxford Dictionary to define abortion, they mention the deliberate termination of a human pregnancy, most often performed during the first 28 weeks of pregnancy. A subset of that definition also in the Oxford Dictionary is the expulsion of a fetus from the uterus by natural causes before it's able to survive independently, and a medical procedure that's performed to end a pregnancy. In 2018, the American College of Obstetricians and Gynecologists, or ACOG, which is one of our national guiding organizations, wanted to put together some standardized terms mainly for research, and they defined abortion as an intervention intended to terminate a pregnancy so it does not result in a live birth. Based on that definition, the previous scenario would be considered a preterm birth. Further definitions, we talk about viability. ACOG does not define viability. The Oxford Dictionary defines it as the ability to survive or live successfully. ACOG defines fetus as the result of the continued development of the embryo until the end of pregnancy. I will use the word fetus and baby interchangeably because some of my patients refer to the conceptus as a fetus, while others refer to it as a baby. Technically, a fetus becomes a baby when it's delivered. Fertilization is an also important concept. It's the process in which the zygote is formed by the union of the egg and sperm. Sometimes people refer to this as a conceptus or conception. This is not a scientific term. Conception is a lay term, and so ACOG very explicitly says that it is not really appropriate to be used in the medical context. So in a pre-Dobbs world, the timing of abortion was really hinging around these definitions of viability. Viability, or the ability of a baby to survive and thrive, is hinged on both the gestational age of delivery. So this baby here is very preterm or premature. And you can see there's a lot of medical interventions going on for this baby in order to sustain life, and also anomalies. And so the discussion of life-limiting or lethal anomalies is a whole talk in and of itself, but here is one such life-limiting or lethal anomaly. This is acrania and anencephaly, which is where the entire skull of the baby has not formed and the brain has not formed. And so the abilities to sustain life for a prolonged period of time in this condition is very limited. After the Dobbs ruling, where the decisions regarding what is considered an abortion and when the abortion is happening opened up a whole other area of routine medical procedures that are now under scrutiny from a variety of sources. So there's fertilization or conception. Again, that's the lay term. This is where the egg and sperm meet to form an embryo. There's implantation, which is where the embryo actually implants in the wall of the uterus. Hopefully, it doesn't always make it to the uterus, and it's not always successful. In the first trimester, there can be a lot of issues about whether the pregnancy is going to continue on to form a baby or whether it is a pregnancy that is destined to fail and miscarry. And then in my world, we often have conversations around multiple gestations where there is not just one fetus in the uterus, but there may be 2, 3, or 4. And so after the Dobbs decision, there have been major impacts in our ability to counsel and manage those pregnancies. So when we talk about a maternal-centric model, as in a maternal fetal medicine, if we just look at maternal autonomy and we just look at maternal non-maleficence and maternal benefit, it is always medically safer for the pregnant person not to be pregnant. These are just 2 examples of studies that are out there. The first, this is a study of ICU admissions in France, and all of these women were admitted to the ICU for a pregnancy provoking indication or for a pregnancy exacerbating indication. This is an older study that does a head-to-head comparison of mortality rates of legal abortion compared to miscarriage, compared to live birth, compared to ectopic pregnancy. And as you can see, the rates for legal abortion for maternal mortality are substantially lower than that for continuing the pregnancy. However, as we mentioned, we're not operating with only one patient. Potentially, there is also the interest of the fetus, and many mothers or pregnant people would confer status upon their fetus to be willing to undertake the risks of pregnancy for the gain of the birth of the child. So when we look along that timeline of starting with the gametes, the egg and sperm, and getting to a baby that can survive outside the uterus, we start with fertilization. And so in my world, there are families that have very significant life-limiting or debilitating genetic conditions that are passed from parents to children. And so with the advent of assisted reproductive technologies, embryos can be created that are from these families that do not carry those known serious life-limiting or lethal mutations. Assisted reproductive technologies are also really beneficial for couples who are unable to become pregnant for either medical reasons or biologic reasons. For example, if someone has cancer that is required radiation treatment, there are fertility preservation procedures where the person can save their egg or their sperm, and that can be used at a later date to have a biologic child after hopefully the cancer is in remission. With the Dobbs decision and the laws in certain states conferring the same moral status on embryos as fetuses as babies at term, the freezing and disposal of unused embryos and even the creation of embryos becomes ethically problematic because, you know, putting a live person in a freezer is ethically immoral. But an embryo that is frozen can allow for that embryo to be suspended in time until such a time it can be either implanted or disposed. And then there's the question of the disposal of the unused embryos, particularly in the case of those that are carrying these lethal genetic conditions. And in assisted reproductive technology, not all the embryos, just like in non-assisted normal conception, creation of an embryo through intercourse, the embryo may not implant normally. And managing an early failed implanted pregnancy is very safely done with medication or a surgical procedure, but this may be considered in the lights of the Dobbs decision as a termination. So moving on into the first trimester and implantation, diagnosing an early pregnancy of unknown location is very challenging because there is a wide range of normal hormones in pregnancy. The ultrasound findings for an early pregnancy, whether it's in the uterus or outside of the uterus, are really challenging. And this is often something that has to be monitored serially over days or weeks. And so in a non-viable or a pregnancy that is not destined to continue, so for example, the beta HCG level is dropping, or you see irregularities in the gestational sac, there are basically 3 appropriate medical treatments: expectant management, medication, and a surgical evacuation procedure of the uterus. This was usually something that in the pre-Dobbs era was fairly easy conversation. Easy in the sense of the medical information, not necessarily easy in the conversation with families, because this is a very sad situation, that the options would be expectant management, medication, or dilation and curettage. However, in the post-Dobbs world, the medication and D&C option are often not on the table because depending on who is reviewing the chart or the procedure, really the expectant management is the only option up until the point where it's irrefutable that it is a failing pregnancy, or it's irrefutable that it's an ectopic pregnancy. This question of termination really comes up, and no longer is it the pregnant person's ability to decide what her risk tolerance is and what her values are as far as moving forward. Ectopic pregnancy is another area where there have been huge strides in decreasing maternal mortality. You can see so an ectopic pregnancy is a pregnancy that implants outside of the uterus. And in the 1970s, the mortality rate was 2 to 4 per 1,000, which is very high. With advancing in imaging technology, advancing in protocols, medication management, and early surgical management, that mortality dropped precipitously. I mean, the denominator is several-fold higher. And so in the early 2000s, the mortality is 1 in 100,000. So early diagnosis and treatment of ectopic pregnancy has been life-saving for women. The problem is that if you are allowing a pregnancy to progress, some of the pregnancies are not just in the tube and may end up being in other locations, which are much higher mortality. So this is an example of an angular pregnancy, which instead of implanting in the uterus or the tube, implants right between the two. This, when expectedly managed, often ends up in surgical treatment with a hysterectomy, which is removing the uterus, so that person would no longer be able to have children. The risk of substantial bleeding requiring a blood transfusion is also higher. There's also abdominal pregnancy. So this is the uterus here, and the baby is completely outside of the uterus. And as you can imagine, with a placenta implanting onto the liver, that is a very, very, very dangerous situation for substantial life-threatening blood loss. The problem with all of these is that the degree of suspicion for an ectopic pregnancy can be problematic because you don't necessarily have the picture of the baby in the tube saying that it's an ectopic. And by the time you get to the point where you have the picture of the baby in the tube, the degree of surgery that's required is much more extensive and the risk of hemorrhage is much more extensive. There also, with some of these trap laws that are being passed, the physician and clinician have to proactively document their medical decision-making to defend their decision. And there is no clear guidelines as far as what documentation is sufficient. There are standard protocols that are how to best manage a pregnancy of unknown location, but they do not qualify what documentation is sufficient. And in pregnancy, there can always be things that don't follow the rules. You can have a heterotopic pregnancy. This is where there is an in utero pregnancy and a pregnancy in the fallopian tube. And so if you remove the pregnancy in the fallopian tube and the intrauterine pregnancy continues, and then that pregnancy goes on to miscarriage, was that considered an abortion or termination? This is where, as Jackie mentioned, the very blunt mechanics of the law does not accommodate for these very specific, nuanced situations where patients and providers really can benefit from shared decision-making. So other pregnancy complications before 24 weeks that can definitely impact the survival of both the fetus and the mother are cervical dilation. So the cervix is the neck of the uterus. It's usually long and closed like this while the pregnancy is progressing, but it can spontaneously open like this. There is a procedure that can be done to close the cervix back down with a cerclage. And so that can potentially prolong the pregnancy on average about 30 days. However, it is not without risk. It may damage the cervix. It may mask subclinical infection. And for people walking around with a cervix that's dilated, it's only a matter of time before they get an infection, the bag of water breaks, and or they go on to deliver. And so prior to the Dobbs ruling, this was really a shared decision-making conversation. Here are the risks of expected management. Here are the benefits of expected management. Here are the risks of cerclage. Here are the benefits of cerclage. Now, in a post-Dobbs world, there are cases of providers being unable to help continue a process that has already started for women who are dilated 3, 4, 5 centimeters, where the longer that cervical dilation is in place, the higher risk of infection is. There is also this question now about if a provider does not offer a cerclage or does not place a cerclage, is that aiding and abetting a termination? The other two areas that are super important are vaginal bleeding in early pregnancy. While vaginal bleeding in early pregnancy is very common, and if it is a small amount of bleeding, it usually does not dramatically impact the pregnancy. But if there's vaginal bleeding to the point where the mother has lost so much blood that she requires a transfusion, the best practice is to evacuate the uterus, regardless of gestational age. That usually is something that is a shared conversation with the family regarding how close they are to the point of time where a baby could survive outside the uterus with maximum medical intervention. But if this happens at a very early gestational age, there is potential for multiple blood transfusions for a patient, which would not ultimately end with a with a baby that would be able to come home from the hospital, and using up quite a bit of hospital resources with the blood. Obstetric bleeding can be substantial. It's not unheard of for a pregnant person to lose their entire blood volume several times over in an obstetric hemorrhage. It's rare, but it can happen. And so vaginal bleeding is one of the things that in early pregnancy is very serious when we're talking about how a person would like to move forward, whether they're willing to risk the potential of further life-threatening bleeding, or they would like to resolve the medical issue with evacuation of the uterus. And then the other scenario is rupturing the bag of water early, or preterm premature rupture of membranes. And there was a study recently that came out of our institution that looked at women who had their bag of water broken before 24 weeks. And those who chose expectant management, only 15% of them avoided morbidity to the mother and had a neonate who survived to discharge. So some people look at these numbers and say, it's not zero. 15% were able to have a take-home baby and did not have morbidity. And by morbidity, we talk about infection, transfusion, ICU admission, hysterectomy, unintended surgery, those sorts of things. Other people would look at these numbers and say, in this situation, there's an 84% chance either I'm not going to have a baby that comes home with me, or I am not going to be able, I'm going to incur one of these serious morbidities and not necessarily have a take-home baby. I think this hard data is important for counseling, but in situations where you are not able to provide the option of uterine evacuation, you are now forcing people to continue with expectant management. So this goes on to some of the laws talk about threat of the life to the mother. And The problem with this is it de facto incentivizes clinicians to watch their patient decompensate to the point at where a complication that was managed with abortion becomes a life-threatening emergency. And this is the question that continually is bounced around in clinician circles. You know, how threatened does the life have to be? And who decides how threatened the mother's life have to be? Is it the lawmakers? Is it the insurance companies? Is it a panel of doctors? Is it the hospital? It really is problematic because with pregnancy, the ability of a pregnant person to compensate in substantial blood loss and infection is fairly good until it's not. So oftentimes pregnant people are able to compensate, and then very rapidly decompensate. And when they do decompensate, they can decompensate very severely. And so in cases of the preterm premature rupture of membranes, the cases of the substantial vaginal bleeding required transfusion, the cases of suspected ectopic pregnancy, in otherwise previously conversations that were difficult but fairly medically straightforward now have become challenging, where people have been having to send their patients to another state in order to get appropriate medical care. So multiple gestation are something that is specific to maternal fetal medicine. And for higher order multiples, so talking about triplets, quadruplets, quintuplets, selective reduction is considered reasonable in the standard of care when you're looking at the pregnancy as a whole. So what a selective reduction is where the heartbeat of one of the fetuses is stopped in order to improve the outcome for the surviving fetuses. So for example, in a triplet gestation, there is an 8% chance that one of those babies will have cerebral palsy, which is can be a mild, but can also be a very serious debilitating condition. In a quadruplet pregnancy, the risk is about 42%. The average gestational age of delivery for quadruplets is around 30 weeks or so. So that usually is considered 2 to 3 months before they're considered full term. And those preterm babies often have a long, complicated stay in the nursery or NICU. By selectively reducing from a quadruplet to a twin or a triplet to a twin pregnancy, the pregnancy has the similar outcomes of a twin pregnancy. So that would be generally delivery around 35 weeks or about a month early, and the risk of substantial time in the NICU and debilitating conditions for the surviving neonates is less. This is an option that is not always embraced by everybody, but it is an option that is reasonable within medical standard of care to offer. Other situations with multiples are if the twins are conjoined, depending on where they're conjoined and the degree of organ sharing. Survivability is from 0 to the ability to be delivered and then potentially have a surgery to disconnect the twins. As those twins get further along, the ability to have a vaginal delivery is almost always not feasible because of obstruction. And then specific to twins, if a baby has a life-limiting or lethal anomaly in one of the fetuses, that may mean that that fetus will not survive the pregnancy and pass away before birth. And because they are in the same environment, the co-twin may be condemned, if you will, to be delivered early. There is also the case of monochorionic twins where they're sharing a placenta. So this is the picture up here, where basically one baby is sort of stealing all the nutrients and oxygen from the other baby. And in the most severe cases, the twin that is losing out on the resources can die in utero. And because their outcomes are linked, there is a 30% chance that the co-twin will either also die or will have an in utero stroke. And so prior to the Dobbs decision, these types of situations were complicated. They were difficult to discuss, but there were options on the table that allowed the pregnant person to decide what their values were and what they wanted to prioritize. After the Dobbs decision, it raises the question of, in higher order multiples, without the ability to do selective reduction, then all pregnant people are subjecting all of their babies or fetuses to the higher risk of morbidity and mortality without the ability to make a very difficult decision to try and have the best chance of a healthy baby that can go home. Likewise, with the cord coagulation of monochorionic twins sharing the placenta. The co-twin is otherwise healthy in a life-limiting or lethal anomaly. The co-twin is an otherwise normal singleton fetus. And so is the outcome of that twin, condemned to be delivered early because of the right to life or the right to attempt to have life of the compromised twin? Who gets to decide which life or lives to prioritize? And again, pre-Dobbs, historically, this was the family. This was the pregnant person making very, very difficult choices, but using their values to guide which path forward they wanted. In a post-Dobbs world, these decisions and these procedures can still be done, but these procedures are generally the most effective and provide the most benefit when done early. And if the referral and the ability to get these procedures is pushed back, they may not be available anymore, and they may not be easily providing the same degree of benefit. So this quote I thought was also good, where it challenges clinicians and organizations everywhere in unprecedented ways, including whether, where, and when, to defy the law and give their patients standard health care and how far to go to provide standard care for medical refugees from restrictive states. So that is one of the things that we have seen here in Colorado. We are a very protective state. So this is from the Guttemacher Institute. We're kind of in the green here as a protective state, whereas the red are the more restrictive state. And so we are seeing a number of folks coming from the surrounding states to get healthcare for a variety of reasons. So a patchwork of laws makes it difficult for the clinicians because it opens questions for us, even practicing in a protective state, as far as what can we document in the record? What can we tell to referring providers? Do people even have referring providers? So a patchwork of law makes for confusion around care. Prior to Dobbs, we would get a referral, we would take care of a patient, we would send the patient back, there would be transmission of medical information, and there would be a closed loop for the patient care. After Dobbs, there becomes this question with the shared electronic records: how much can we document in the chart without putting the patient or the local provider who may have talked to us about the patient in liability? For people who are getting delivery of the fetus for medical reasons, there can be gaps in care and follow-up for chronic diseases. So if they came to Colorado for a termination for, say, a cardiac disease, we would generally want them to have close follow-up within a week or two to make sure their cardiac disease is improving. Now, if we're not able to give that information to a care provider and the patient does not have the resources to stay locally, and we do not have a license to practice in the state where they're from, there is this gap in care. There's also gaps in care for follow-up on critical results. So we talked a little bit about genetic abnormalities. So if the fetus is coming to be delivered for a genetic abnormality and there's genetic testing or an autopsy, we are unable to counsel the patients about these results and the implications of these results for future pregnancies in their families. We also not always can talk to the provider who referred them to do this counseling locally because there are restrictions in referral for abortion or termination. Providers who are practicing in restrictive states, did they have a healthcare obligation to stay in those restrictive states? Can providers in our state who provide care to people who are coming to from another state, could we be extradited to that state? And what if we travel to one of these restrictive states for a non-work purpose and somehow it becomes known that we provide this care in our home state? Does that put us in jeopardy? I think there's a lot of questions that providers are concerned about, not only about providing medical care, but for also their personal safety. So skipping gears a little bit, we talked about it's always safer to be not pregnant. What about if we're not giving people a termination when they want it? So I think this also, this is one of studies that looks at what happens if someone comes in and wants a termination but doesn't get it and carries the pregnancy to term. This is a study from UC San Francisco. It was recruiting patients in 2008 to 2010 from 30 abortion clinics around the country. And about 1,000 women were included in the study. And those who were turned away were beyond the gestational age limits of the state restriction. And so that's another area where there's some restrictions. And so these folks were followed for 5 years with interviews to see how their outcomes were. And I think if you read through this, you know, the outcomes are not only the health outcomes of the pregnant person, including chronic conditions. There were 2 maternal deaths for those who were forced to continue the pregnancy, while there were no deaths in the abortion cohort. There were other social implications of not getting the termination. There was increased intimate partner violence. There were increased difficulties within the home, and there was increased poverty and decreased upward social mobility. We also look at the World Health Organization, and they have updated their guidelines to say that, you know, when you look at the data, does restricting abortion decrease the number of abortions? And unfortunately, the data did not seem to support that. And it just increases the risk of unsafe abortions, which is a leading but preventable cause of maternal death and morbidity worldwide. It also talks about the findings that it can lead to other burdens for women, communities, and health systems. And they argue that lack of abortion access is a public health and human rights issue. As a caveat to this, the maternal mortality in the United States compared to other developed countries is much, much higher. And potentially one of the reasons for this is the lack of access to safe, appropriate care. And so not only is it a lack of access to care, but also the ability of pregnant people to make the decisions about their own bodies. So switching gears a little bit, what about training for our future generations of OBGYN providers? So these are the maternal deserts in the United States. So these are the number of OBGYNs per 10,000 people. And I acknowledge that there are some rural communities where obstetric and gynecologic care is provided by family practice providers and nurse practitioners. But this is one of the things that when you look at maternal mortality, the push was to try and create more access to care in these regions where there aren't providers. This is a map of distance in miles in order to get an abortion. And you can see, not surprisingly, where there's no OBGYNs, there's no access to abortion. So when the Dobbs ruling was coming down, the Accreditation Council for Graduate Medical Education, or the ACGME, talked about the requirements for training as an obstetrician gynecologist. And in some states, abortion is a felony. And so having your residents train in a procedure that would be considered a felony is very problematic, to say the least. The problem is the evacuation of the uterus for a non-viable, non-continuing pregnancy and the evacuation of the uterus for abortion is the same surgical technique. And so by not allowing training in abortion, you're also not allowing safe training in management of early pregnancy that's not continuing. Unfortunately, about 45% of OBGYN training programs were in locations where bans are implanted. This is almost half of the OBGYN residencies. And the ACGME said, well, rather than changing best practices for training our next generation of physicians, the programs now have to provide access to a jurisdiction where no legal restrictions are present. And so basically residents will have to travel out of state to get this training. And if residents are unable to travel, then the program must offer a combination of didactic activities, including simulation. So I think that's important, but at the same time, simulating doing a termination or an evacuation of the uterus is very different than having someone with substantial hemorrhage or learning the language to be able to counsel a patient and to be with a patient through a very devastating time in their lives and provide them emotional support. It is very different than doing it on a plastic mannequin. So it's not just OBGYNs that are going to be impacted by this. Basically, all medical students in training with states with substantial restrictions will not get the same training and the same ability to diagnose and manage early pregnancy complications. They will not be able to refer in the same way. And there are impacts for radiologists. So an ectopic pregnancy is considered a critical read. In states that are more restrictive, radiologists may be more hesitant to call it an ectopic pregnancy. And so there may be a delay in management, which increases the morbidity of the patient. Emergency medicine physicians often will see first trimester bleeding or ectopic pregnancies. As I mentioned, family practice physicians also often manage obstetrical complications. And for anesthesiologists, if a pregnancy needs a surgical procedure, they are often the ones providing, or they're almost always the ones providing pain management for the patient. And so this is a quote by Dr. Steiner that says that, physicians are obligated to give information and to refer. And after the Dobbs ruling, they are distressed and worried as they are told by lawyers they cannot give this information, they cannot refer, and cannot medically do the right thing. So just a few resources before we're wrapping up here. There are resources for patients when they are trying to decide how they want to move forward with a pregnancy. So findsupportalloptions.org and pregnancyoptions.info are non-directional values clarification websites. There's a few workbooks on there where families can go through and try and decide what is the right path forward for them. Return to Zero has a lot of great resources, but in pregnancies where there is a lethal life-limiting diagnosis or there's a maternal complication that makes pregnancy a very dangerous prospect for the mother, there's some information for that. If someone decides they are wanting to move forward with a termination, there's the National Abortion Federation and the Cobalt-Axton Fund, and that can help coordinate care. For these situations like heavy vaginal bleeding or ectopic pregnancy or previable PPROM or selective reduction, previously this was something that a provider could counsel and refer. With some of the TRAP laws, that's no longer available. And so some of the onus becomes on the patient to coordinate their own care, which can get to be very complicated and very expensive. And then for patients with life-limiting or lethal anomalies, there is the option of perinatal palliative care if they choose that, and there's some resources there. As far as resources for providers, they're a little bit limited, unfortunately. Institutional counseling and peer support can be very helpful. The medical information about abortion hasn't changed, and so there are some facts from ACOG. The IPASS, the National Abortion Federation, do provide some other resources and support for providers who are feeling in moral distress. So just a couple of voices from the OBGYN community. So from an ethics standpoint, I think it's important to highlight the moral injury that both patients and providers face when they cannot access or provide optimal medical treatment. And then from a provider who was in a state that was very restricted, this person was talking about being worried about being in a situation where I was going to put my own freedom and life at risk in order to take care of someone and make sure they didn't die. And so, on one hand, as physicians, we're obligated to protect patient autonomy, put patient welfare above our own, provide patient-centered care, promote social justice, and do no harm. We have all these obligations, but the laws are asking us to not abide by those principles. On the other hand, when we look at, one poll as far as abortion views, very few are on the far end of the spectrum where it should be allowable for everyone. Few are on the end of the spectrum to say it should be allowable for no one. I mean, we're all kind of trying to navigate this gray area. And if we close up the gray area and we don't allow for it to be in place, we're really doing a disservice to our patients and our providers. I'm going to skip over that quote there. And I just want to thank these providers who helped review my slides. And I think we're up for some questions and comments.
Okay, thank you very much. And I am going to kind of monitoring the chat here, and there are some questions. The first, someone wonders about the ethical considerations of these laws forcing providers to leave their jobs for fear of legal retribution. What does that mean? That will be in a society where less people are willing to treat women's health in all its complications.
Yeah, unfortunately, I think that is the truth. I mean, we already see it with the healthcare desert. So if you put a map of maternal mortality over that map of where there aren't obstetrical care providers, they're almost superimposed on top of each other. And so it becomes problematic because then the care can be provided by mid-level providers or family practice providers, which is not necessarily a problem, but for certain very complex situations, it would not be appropriately managed. The other problem is the distance to travel. So we basically would see women with that if the complications were managed earlier, they're going to be further along, and there's going to be maternal morbidity and mortality. If you look at neonatal and infant mortality and you superimpose it across those same graphs, the areas that highlight or are higher for infant mortality, it's that same area. So it is a real public health crisis in already low resource areas. I would imagine if we looked at that map in 5 years from now, there's going to be even fewer providers and more healthcare deserts for maternal care.
And to
Wonderful.
add to that, I don't think it's fair to put our healthcare providers in this untenable situation where they have to choose between their own safety and livelihood and the safety of their families and the obligations to their patients. I think that's beyond ethically problematic. If we value healthcare, we value the professionals that provide the healthcare, and we are obligated to support their medical healthcare decision-making. And so they don't have to choose between their livelihood and their families and their obligations to patients. I think that's a societal obligation on us.
Jackie, following that, going beyond moral distress to moral outrage, just wonder, are there ways in which this moral distress or moral outrage is being addressed actively with folks around the country, with clinicians?
I don't know, Julie. That's a great question. Moral distress rounds are available to our providers in our hospital. We have debriefed some really challenging MFM cases in the past where there was a lot of moral distress. So that's available locally. I haven't seen on the clinical ethics chats, I haven't seen in the literature the use of the language of moral distress and moral injury. Matt Winia, who's the director of our Center for Bioethics in Humanities, is in the literature calling for conscientious objection of the positive kind, not violation of my conscience, so I'm not going to do it, but violation of my conscience and professional obligation, so I'm going to defy the law. But that's, I'm not sure how practical that is without widespread support. So individuals don't end up in the same pickle, choosing between their families and their patients.
Thank you. To either of you, can you speak to some of the ethics regarding termination in a state like Colorado, where there is no legal limit and laws are overall protected?
So I think that is interesting because Colorado is unique in that sense. And I think from a provider standpoint, I mean, it goes back to that question of viability of the fetus. And so there are some folks on the end of the spectrum, like Jackie mentioned, where there are no limits, and those limits should be decided by the pregnant person. And there are others, again, generally, if you have the view of two patients, then you are trying to balance their views. I think it becomes, from a public health perspective, where we are a location where we get volume from out of state. And so then it becomes a question of justice and access to resources. I know many of my colleagues who do the challenging work of managing a lot of these out of state patients. Not only is it volumes in the clinics, but it's also the ability to consult with people out of state to help them have that shared decision-making. And potentially you're doing that across state lines. And that can get really hard because if you don't have a medical license in that state, you cannot practice medicine, so you can't give specific medical advice. You can give very general medical advice. And so I know that it can be challenging because you may have someone who's traveled a long way being told one thing, and then when they get here and you make your own assessment and evaluation, it may not be the same story. And then you're put in this position of, do I continue with the original plan, even though I have some, moral qualms about it, or is it something that is still medically reasonable? And so I think even in a state where we don't have the restrictions like you might have in another state, there still has huge impacts because of the people who come here, the people who are referring them here, our colleagues that we want to support in other states, and these situations where, viability is a very, as you said, squishy concept. And so I think it's a unique set of ethical challenges.
And there's several levels to this question. Thank you for it, Julie. I'm happy and glad that I work in an environment that embraces the maternal fetal dyad and obligations to each. And I think Roe got it right. It's easier to be no circumstances, all circumstances. But I think the moral challenge, the ethical challenge, is to strike the balance. Everyone has to strike the balance. But push comes to shove. I do believe that the person in the best position to strike that balance is the pregnant person herself. With her narrative, I saw Carl's point about narrative. She understands her situation, her values best, with her family, with her faith providers, with her healthcare providers. At the end of the day, I trust women to make decisions that are best for themselves and their families over the state.
Thank you, Jackie. Okay, it seems that much of the state legislation limiting abortion was written without a lot of input from physicians. Many of the interviews with physicians post-Roe that I've heard have been pretty strident and oppositional to the Supreme Court ruling. Is there any attempt by ACOG or other professional groups to reach out and partner with legislators in restrictive states to recraft legislation that limits abortion while at the same time gives consideration to these complicated medical situations?
Every organization that is supporting OBGYNs, even the conservative, there's a conservative OBGYN anti-abortion group, and even they say that like ectopic pregnancy management and termination in the first trimester, or evacuating a uterus in the first trimester, is not considered an abortion or termination. And so ACOG, the American Society for Reproductive Medicine, the family planning organizations, the Society for Maternal Fetal Medicine, across the board, the advocacy arms of these groups are really trying to do their best to help protect women's health care. But I think part of the problem is in states that are on either end of the spectrum, there is less willingness to be in this gray area, to talk about these situations where there really isn't, in my opinion, a right or wrong answer. And so it is very hard to have dialogue in places where there are such stringent views and there is no wiggle room for any exceptions. And the definitions are problematic to begin with.
And I think we should attend to our obligations writ large. I'm in pediatrics. I care about babies. I care about children. I care about the circumstances, the social circumstances in which a woman finds herself with the only choice of abortion, rather than being surrounded by the means necessary, that she has a real choice not to consider abortion. So I am very sympathetic to Cardinal Bernardin's seamless garment of respect for life in all its manifestations, from not just fetuses and reproductive health to access to healthcare, to gun safety, to war, to capital punishment. I really respect the attention on our parts to be obligated to our neighbors and friends and our families to promote well-being for everyone.
Thank you. There are a number of really good comments and questions. We have time for one more. Those others hopefully will be able to get back to you. One of the questions, though, is could you discuss the distribution and access to mifepristone? Recent appeals court ruling has impacted many telemedicine abortion services and clinics.
No.
This is a very complicated answer. Yeah, I think it's a problem because medical management and self-management of abortion medically is shown to be one of the safest procedures you can do. And when you look at those slides about the risk of continuing a pregnancy, you know, there's a non-zero risk. You may end up in the ICU or you may die with the pregnancy. And so I think this forcing people to continue pregnancy is problematic, and removing one of the safest ways to resolve that situation is also very problematic. The slide I skipped over, as far as the quote, kind of, I think is very dramatic. So, you know, if you're talking about being pro-life and trying to preserve life, you know, if we really are pro-life, we would, you know, demand that people donate blood or bone marrow. We don't demand kidney donations, which are less risky than childbirth nowadays. And so I think it's incredibly problematic that we are not looking at the whole picture. We are looking at very narrow view on things, and we're restricting medical care that's very reasonable. You know, it's like restricting insulin for diabetics, right? We could say, well, we sort of restrict it because of the cost, but, you know, that's a whole other conversation. But it is incredibly problematic. And I think the repercussions are going to make women less healthy and less safe. And when you look at the Turnaway study, that's not only women, it's their children, it's their families, it's their communities. I think it's incredibly problematic.
Yes, very, very well said. And we haven't even gotten to the healthcare equity issues and justice. This is so complex and so broad, and yet you really have given us a lot to work with and spoken so well to it. So thank you very, very much, both of you. Really, really appreciate it. Also, again, this has been recorded and people can access that on the Colorado Bioethics.org website. Want to invite you to join us in another month on May 11th, I believe it is, on ethical considerations for returning clinical genomic results from a population biobank. So it should be a very compelling presentation next month, and look forward to you joining us then. Again, Dr. Glover, Dr. Straub, thank you very, very much. Really appreciate it.
Thank you.